Are live. There we are. Colin Rigney. Now I'm going to read this. Hopefully I get it right because I wrote it down to make sure that your official position is the co-director of education and advanced musculoskeletal ultrasound center. Did I get that right?
That's correct. Yeah, I would say co-founder, but
Okay.
yeah, my co-director, co-founder, co-operator, a lot of hats being worn.
Not just to kind of jump right in, and we got a lot to talk about because you and I have a lot of things that we both. It's your profession. It's kind of my hobby, the body, as I've played pro sport and have been in training for a long time. And at one time had considered being a doctor because I find the body fascinating. As we were talking the pre-show, all the different things that take a role in it, and I'll touch on that today a little later. But musculoskeletal ultrasound, it's not something that seems to be in the mainstream as of yet. So can you kind of just clue everybody in on what that is and what it is that you do, in addition to, you're orthopedic physical therapist, you're a doctorate in that, and you've got a lot of initial or letters after your name, that you have a lot of different expertises. But I want to start with what someone might see the title list and say, what the hell is musculoskeletal ultrasound? So let's just start there to make it simple.
Yeah, so musculoskeletal ultrasound imaging. So ultrasound is actually the oldest imaging modality. It predates X-ray and any other imaging tools that you've seen. And we use that same technology to evaluate the musculoskeletal system. And the reason why it's not mainstream yet is the training. It's only as good as the person who's operating it. Okay, but I've seen major strides coming in the recent, I would say, 5 years. It's starting to get there. And the whole purpose of us starting the company the way we did is we want to elevate the profession of physical therapists to practice more autonomously, but also at the same time collaboratively with our physician colleagues, because us knowing the body system, the kinesiology, the anatomy, all the special tests, all of that goes hand in glove with being a good operator with diagnostic ultrasound. I tell people to think of it like it's like a stethoscope for the musculoskeletal system. So within a matter of seconds and minutes, you can get the status of the health on whatever tissues you're evaluating. Okay, and the types of tissues we're evaluating with ultrasound are muscles, tendons, ligaments, nerves, synovium, bony interfaces. It gives you an idea of the joint interfaces. It doesn't see through bone because sound waves don't penetrate through bone, but we can get a good idea of the outlines of joints and whether or not we need to correlate what we're looking at with another imaging tool. That's really kind of the special sauce in the training, is knowing when ultrasound's enough, knowing when you need more, knowing how to have the conversation with the patient. It is so much more than just the technical skill of taking pictures. It's very much an art in being a provider, okay? And knowing how to assimilate what you're looking at, translate it into a conversation. It's really a great medium for communicating with the patient or communicating with another physician. So my role, I work as a physician extender for different sports physicians around town, orthopedics, you name it. I've worked in the setting, worked in surgery centers, doing consults for all kinds of different ultrasound guided procedures. And that's been my background for, almost 15 years. And again, back to the mission of what we do, I take my foundation, because my foundation is as a physical therapist. I did do a residency in orthopedics. I do have an additional certification in orthopedics. And without that, not everybody needs that foundation, but without it, for me, that's what allows me to utilize the imaging tool of ultrasound to its max capacity. And it's again, it's really our mission to get it, really get it more out there. and we want a good reputation. We want to train people to do it the right way.
Do you find in a very that you have the perspective that you have based off your education and your experience, and as you mentioned, you did a residency in orthopedics, so you have this wide perspective on able to diagnose what the cause is, as opposed to just a symptom. Or I'll do a very rude comparison. You versus somebody just coming out of school. I know that's a distinct difference because they're not going to have the experience, but the experience is what I'm getting at. Not only experience in the ultrasound, but also in the orthopedic section and in all facets of the industry that you're involved in. So the question is, do you find sometimes that explaining what you're seeing or what your analysis is difficult because some of the people you're explaining it to only have the perspective of being very narrow per their discipline?
The answer is I used to have more difficulty doing that. As I've gotten better and more experienced over the years, I've learned how to talk in very simplified terms. And there's a few laws of communication that I follow, and the main one is you have to meet people where they're at. And if you don't spend a few minutes front loading some rapport, conversation, getting to understand, the why behind what you're doing. Once you get that buy-in from people and you can understand, more about what their mission is, if they're a new clinician or if they're a patient who doesn't know what they're looking at, the conversation is the same, in theory. You have to be able to break things down in a way that people understand. Now, if somebody's level is higher and they have a medical background but they don't know what ultrasound is, I can, it's a mix and a blend of how I want to break that down. And so I use a lot of analogies, but certainly it goes back to, and there's all kinds of examples I can use, but really I just go back to, you just have to meet them where they're at. And so figure out where they're at. And that's how I know how to explain it. Sometimes I go deep, sometimes not.
I tell you where I run into that in golf and coaching and I was very lucky to come across some very, very, very smart people in their particular sections of the golf business. One was a club fitting guy, and to this day, the club fitting side of golf, in my opinion, is going the wrong way, where they're all talking about now, because of the use of some of the technology, and I think they have the equation completely wrong, is that flex of a golf club is, if there's a list of 100 things on club fitting, flex comes in 50 to 52. And I'm like, you're out of your mind. That's only because you don't understand what the human body produces as far as an energy standpoint to max the energy that the shaft is designed to give and to function correctly. And so there's that. And I have spent a fair amount of time with Jeff Mangum, who is considered, I don't think he's very well liked within the industry. For some reason, he likes me and we get along. But Jeff rubs a lot of people in the golf world the wrong way. But I think everybody would agree that there's nobody on the planet that knows as much about putting as Jeff. And so I've spent a lot of time with these people, and I will sit there and I'll give you a quick example. And this is the genesis of that question and why I ask people in other disciplines or fields. There's a local assistant here, and he wanted to debate me that putter style, offset, center shafted, heel shaft, all these different putter styles can make a significant difference in how someone is able to putt. And I said, putter head style has zero to do with any skill development putting. Now, according to Jeff's system, and I have a tendency to believe what he says, there's 4 skills involved in putting. Putter head design is not one of them. Because, and I told this kid, I said, you're hitting the ball with a flat face. And you have to send it, you have to read it correctly, so you have to have the line correct. You have to be able to align that putter face perpendicular to that target line. And then you have to be able to send the ball off on that line with the correct speed. I said, and where in those 4 things does putter head style come into play? And he just arguing with me. And I'm like, you're arguing physics and design, but it doesn't come into skill development. So
I love it.
I try to educate, and I get to a point where some of these guys and they're masters on Google is what I refer to it as. And I give them credit. They're at least trying. They're not just sitting there being complacent and just not trying to improve or become smarter, educate themselves. But I think it becomes very dangerous in every field. Getting on the internet and what you read can be just as detrimental as not reading something at all. So it's like, be
Yes.
very careful, be very selective in whose information you read, because you could be going down the wrong path and
Yep.
actually hurting people more. And I definitely see that in the physical fitness and therapeutic sides of things, and
Yep.
diagnostic, which I think is largely what you're in, more diagnostic now than you are in therapy or rehab and things like that.
Correct. What you just described about the putter and its relativity to one's skill, and its, you know, how effective it is for, you know, what needs to get done. That's ultrasound. So it's only as good as a person using it.
Mm-hmm.
Okay, right. And so that's what I took away. And that's the same thing with diagnostic ultrasound. We can talk about the limitations of it. We can talk about, you know, its comparison against other imaging tools, one's preferences, and that sort of thing. But it comes down to operator dependency, right? And that is the experience and the skill and the training of the individual who's using it. Okay, so it's just like, you know, I have an iPhone, you know, and, you know, you have you know, my kids are getting a little older now, but if I gave it to my 3-year-old, you know, he would like slobber on it and go look for, you know, Bluey YouTube or something. And but if you give it to somebody, you know, like a Bill Gates, or, you know, right, they can build an empire with it. It's just, how do you want to use it, right? And so that's our mission with ultrasound. And yes, that's my niche. But certainly I've spent a lot of time in gyms. I've been in the industry, like I said, my dad was a physician. And so I grew up making house calls. I was in the OR, you know, from a very young age. And I learned a lot about communication from him. And, you know, he would do rounds in the hospital, rounds in the nursing home. I would go with him. Me and my brother would. And see how he can just have this range of communication skills and be able to get what he needed to get out of the encounter, you know, just at will. And you don't really appreciate that until you get older and start doing some of the same things. And I imagine it's very much the same thing in coaching. Well, I've done a fair share of coaching too, and mainly weightlifting and basketball. But in golf, where, you know, coaching in golf is somewhat analogous to coaching in ultrasound. It's very much a one-on-one setting. Very much there's almost a tool for every situation, right? You never hit the same golf shot twice on an 18-hole course. You know, we try to simplify it a little bit more on the ultrasound side, but here's the thing: not everybody's body's going to be the same. You know, you have diabetics, you have hypertension, you have all these things that affects the way people's tissue looks, and you have to be able to modify the machine and modify your eyes and modify your thought process as you're evaluating somebody with a healthy background, or they have a multi-system kind of consideration in their health history in the evaluation. So
when you do your evaluations, as we're talking about, you know, aging and being, we'll call us, each of us, former athletes.
Yeah.
Although I don't know if the inner athlete ever leaves you, but when
No.
you play enough sports, you do enough training, you do enough of these things, your body tends to suffer injury. And if you're looking at, let's say, somebody's shoulder, that they injured what they believe to be the rotator cuff or something in their shoulder, but maybe they had a knee injury when they were in high school or college, and then a low back injury when they turned pro, or whatever it is. You know, people can use their imagination. I would assume that in the question, that you have a questionnaire that you, when you have patients come to you, that you say, please tell us prior injuries and so forth, because you're going to be able to determine, or based off what you're seeing with your experience, if somebody's shoulder, if the fascia or the soft tissue or the musculature and the bone structure is showing a certain way, you have looked at enough film and done enough study that you're going to say, okay, I've seen this before, and this is also affected in this portion of the back. Oh, look at their chart. Yeah, they had bulged a disc when they were 19 years old, and oh, look at this, when they were 16 playing soccer, they strained their knee, or they tore their ACL, whatever they did. And you can start putting these pieces together to a certain individual on your diagnosis that is going to be much, much better in what you have them do going forward.
Yep.
So that the remedy actually works, and it's not just I call it throwing darts in the dark.
Yeah. Yeah, absolutely. So, one example I'll use is you threw out the rotator cuff. When I see a 50 is, let's just take it's somebody between age 50 to 70, and they have they have a athletic background. I can already, and they're coming in with what I suspect is a rotator cuff issue. That's going to be the primary focus. So I kind of know what I'm going to see when I go into that rotator cuff exam, but secondary and tertiary, you can almost always throw in, even if they didn't put it in their questionnaire, I know that they have some level of thoracic and cervical dysfunction just by demographics. It may not be active, meaning they might not be symptomatic at the time they're seeing you, but they have something like that in their history, or they're heading into it. And it is very important to evaluate that as well. And specifically where the cervical meets the thoracic junction, in this relation to how the scapula interacts, right? Over time, right, we form this more of a kyphotic posture. Okay, that has a direct impact of how the scapula moves against its rib surface. Okay, and by nature, we're talking just millimeters in some cases. That impacts the glenoid in the humeral head. Okay, if that's just shifted, protracted slightly in one direction, okay, then we're talking about massive impact on the rotator cuff. But you reverse engineer all that and go back, okay, you should also be addressing their scapular thoracic and their CT junction and maybe other levels of the cervical spine as well. I don't even have to read their med history most of the time. I can, now, but it's certainly something that it comes in clusters, man. Very rarely, just like, if somebody has plantar fascia and is chronic, I know that they're either developing knee issues or they're going to be developing a knee issue. And then that'll translate into, maybe a hamstring contracture or something up in the hip, depending on what their activity levels are. But you have to treat things and you have to evaluate things as a system. And your system has to be duplicatable in how we're training people, right, to evaluate. And so just like Dr. McGill has his McGill method, right? We have a similar method of how we train operators to use the ultrasound. We don't want to train people to be technicians, but you have to be a clinician and really expand your perspective and scope in the evaluation process. So when it comes to those, I love treating the older athletes. Number one, because they're mostly always motivated. Rarely is anything like beyond repair. Okay. Now, expectations are always set with, we're not going to get you back to like 25 years old anymore, but, realistic expectations are, you want to get to a certain level. You want to do things without the same level of pain. Okay. I want to know what that is, so we can peel this back now and really work on what it's going to take to get you there.
The things that you have to deal with, I can only imagine that it's for someone like me who just understands fascia, muscle system, soft tissue, ligaments, tendons, interconnections, and only because I've been around it enough. I've taken enough classes. Guy Voyer's, when I was working with Dan Hellman, I took some of Guy's classes when I just happened to be in town when he was there. And I mean, it's fascinating to me that all these things work. As you said, you have to treat it as a full system.
Yeah.
But what blows me away is that someone like you is able to look at all of these things and have the technology to do that, but then to be able to take not only their history and all the things that they've done to themselves and what training they've done, but as all these things are interconnected, you're able to come up with a way to get them out of pain and back to moving when you've got hundreds, if not hundreds of thousands or even millions of of variables that are all
Yeah.
playing a role in this person's pain and their inability to move the way they want to. And I just sit there and I just shake my head. It's like, it's like watching would be like watching someone do it, like a Picasso do a painting, or a Da Vinci do a drawing. You just sit there or I use the golf one that a lot of people at clubs are in awe by. Is a very simple one, is the calligraphy. When they do the scoreboard, it just, how can they do that? It's just, it looks so intricate. But again, it goes back to your training. And if anybody looks at your background, again, you said your dad was a doctor. I mean, from a very young age, you spent time in and around the industry, and then you obviously have an extensive educational background in what you're doing. So you have the broad scope with the general medical, and then you have the specialized.
Yep.
That it takes years and years to be able to do what you do.
Yeah.
With the different, how would ultrasound, as far as what you utilize it for, sports injury, or people just coming to you because they've hurt themselves in one way or another, how would that differ from the other things that people are using, like MRI, CT scans? How does it differ, and then how does it have a major benefit over the other ones, or are there certain instances that each of those seems to be the one to go to?
Yeah, that's a pretty good question, and that could be a whole show on its own. So what I'll try to do is just do an overview on where ultrasound fits amongst those other ones. MRI is still the gold standard when it comes to seeing the three-dimensional joint. Seeing everything from the inside out, outside in. Like, you're not going to really miss anything if the operator is good and looking through an MRI. Okay, but MRI comes with a few downsides. It comes with, creating another visit to go there. It's not a short procedure. It takes time out of the day. It takes time to get it read, and then hopefully
those tables are never comfortable either.
Tables are never comfortable. We can go. There's a whole laundry list of it. You got to wait for the read. Sometimes the read is suboptimal. Sometimes if the order wasn't done correctly, they weren't looking for the right thing. Sometimes the slices weren't ideal for certain structures. Yada yada. And ultrasound, I'll be upfront that ultrasound in the hands of a really good operator can really limit the use of MRI because you just don't need it in a lot of cases. And I'll just say, for anything that's extra articular, so anything that's outside of a joint capsule or barely visible past the joint capsule, ultrasound is actually superior in resolution. So I really, I limit that anything that's not like a superior labrum, an ACL, a PCL, maybe some deep meniscus root tears, and we're taking the spine out of it because that's not an ultrasound. We're not really diagnosing things in the spine with ultrasound. That's a whole separate structure. Ultrasound really, for all these for the peripheral joints, the way I described it's actually superior than MRI in its resolution, and it's all, and you're taking out the middleman of the third party read. You're taking out you're saving them the expense in the healthcare system, the expense of the more expensive machinery. You're cutting out the patient's time that it would take to do all those things. And you're getting it done at the point of care level. Now, like I said, sometimes I get through an exam, I'm like, wow, that was really complex. Because it's always good to have a healthy level of fear even when you get to a level and you're an expert in, it's good to have a healthy level of fear and make sure you're not prejudging anything. If I come into something that's like very, very complex, I need to get another read on it. I'll either, contact my physician colleague. I do have a couple of radiologists I can run it by. but we always have an MRI in our back pocket if we need it. Okay, for full transparency and disclosure with the patient. Even though we got some good things out of today's ultrasound, there are a few data points on here I'm unsure about, and I'd like to use an MRI to get a better read on it. So that's MRI and ultrasound really are kind of the co-pilot, or they're like passengers on the same plane when it comes to evaluating the musculoskeletal system. CT is, depends on what area of orthopedics and sports you're in. Okay, I would say CT is leveraged higher by trauma orthopedics. It's very much a point of care imaging tool in the trauma setting. Is somebody comes in with an MVA or some level of trauma, and you need to get a good evaluation on the bony surfaces. You're suspecting fractures, not just fractures, but what kind of fractures, how many fracture fragments. It has the ability to be three-dimensional. So I don't know if you've ever seen, Pete, those 3D CT scans. Beautiful.
Well, plenty MRI, but never CT.
It's crazy. You should look at it. 3D CT for orthopedic trauma conditions, and it looks like an artist drew it in color. It's amazing. And in the hospital setting, when time is of the essence, it's the best tool to evaluate what kind of fracture management are we doing right now, and I need to know, right? That's CT's best one of the best things that CT does in the MSK system. I am not the authority in the space to define all these things. I just have to be aware of them all and how they fit. CT is also very good for surgical planning. If somebody's going to get a total joint, it's very arthritic, and they've exhausted all the other non-operative means to get better. The 3D CT scan really allows the physician to pre-plan the surgery with better precision, and as well as it's very much superior in identifying bony anatomy, even better than MRI. For spinal conditions and in a lot of spine cases, if you're suspecting some kind of fracture or spondylolisthesis, MRI is going to give you more detail around the disc health, the end plates, the annulars, the annular ligaments, and those things. But CT is very much as far as like outline of anatomic detail. Like the imaging that it's able to give you now is, like I said, it's like an artist drew it. You couldn't draw it any better. So how that all fits with ultrasound is, somebody like me and whoever we're training need to know where it fits on the hierarchy. And we're not putting people into camps of team MRI, team ultrasound, team CT, whatever, X-rays. Everything has a place, just like in your golf bag, right? Everything in your golf bag, there's a tool for when it's needed. And sometimes you don't use the tool very often, but when you need it, you want to have it. It's the same thing with imaging.
That makes total sense. I think when I had Dr. Geyer on, the famed Texas Back Institute back disc replacement surgeon, I think it was written on. I don't think I asked him. I don't even think I insinuated, because I know he can't say so, but the golf world was very, very confident that he was the one that did Tiger's latest surgery before he came back in 19 and won the Masters. But we were talking about the specificity of getting a disc in replacement disc in the right spot, that how important that is, or else if it doesn't, you're basically going through all this surgery and you're right back where you were with an uneven disc, and then everything getting irritated from there. And the amount, the detail and precision that he and his team are able to do with that. And I don't remember his CT. It was obviously the latest and greatest technology on imaging and things like
Yeah.
that on what to do. I think it was CT, and I could have it wrong, and somebody could comment, which is fine. If you're going to comment, let us know what it is if you do know. So, but yeah, it's phenomenal what the medical industry can do nowadays. In as little as um, the last 3 to 5 years, as fast as we see everything in our world changing around us, and technology has its impact on that. I can only imagine, like in your field, how much things have advanced in the last 3 to 5 years. Is it? Do you sometimes look at it and shake your head, or are you saying, "Well, we're lagging, and we need to. Our industry needs to step up." Where is your field with technology and its implementation for effective treatments and diagnosis?
Yeah, I think that when you really sit back and look, you know, it's really come a long way. Now the tendency there's negative tendencies in the profession that, you know, there's quite a bit about the medical industry in general that, you know, is the old standard of care is still too predominant. But when you really sit back and look, like the advancements that we've made, you know, have been really, really, really good. You know, I I haven't seen a bad disc replacement come see me yet. That wasn't even a thing when I first started, and it was either, you know, it was either you go through a series of discectomies, laminectomies, whatever, fusion, you know, and you know, fusions are, you know, seems like they certainly have their place, but and I think that if that's the tool we're using, like that's is very hard to um, live with the fusion long term without affecting the upper and lower levels down the road.
Mm-hmm.
And you just look at that as like the first surgery. Now, with the ability to replace the disc instead of fuse the area, you take out. I mean, it's just come so far. Like I said, I mean, people's motion's restored. You have the loading considerations that are a little bit different that we don't get training on in school and stuff. But if you just take the principles of normal bone healing and what it takes for the body to accept that new disc, and you progress them along those principles, it's very hard to screw them up. Most people get better. Most people get better if you don't push them too much, to be honest with you. And so you want to give them just enough that's therapeutic and inch along rather than try to push, even if they are an athlete. And I've seen a number of athletes, like high level, professional level athletes, come back from, you know, with a disc replacement. And it's phenomenal.
I was blown away that Doc Geyer told me it is basically outpatient surgery. He said that he keeps his patients there overnight for observation, obviously, because, and the other thing that I was very surprised with was they have a general surgeon there because they go in from the front. So they have to move you know, your innards, your intestines and things like that to access it, which for anybody who knows human anatomy, or if you don't, it's so that they don't have to slice through all the layers of the musculature of the back. Because if you do that, you're really, your chances of coming back are significantly depleted.
Right.
You go cutting through muscle, but they go through the front, which is amazing. But then that he says, you know, once they get it in place and you're put back together, literally, you know, you're walking the next day. They want you up and moving.
Yep.
And they send you home, and here's your instructions. I think he told me that it's 3 months of your really only physical activity is walking, no lifting, anything over 5 pounds. You know, picking something off your pair of shoes off the floor. And then at about 6 or 9 months, you can go back to lifting some things, daily things. And then at about maybe it's 9 months to a year, 18, you know, you can start being physically active with weight training and things like that. And I think that's absolutely amazing.
It's crazy. I know. And the joint replacements now have advanced quite a bit. The time that they're actually spending to do the surgery has been reduced. And this is not to mention the field of orthobiologics. So things like PRP and stem cell for the management of orthopedic conditions. I mean, it's there's a whole podcast to be done on that. So
Mm-hmm.
these advancements have rapidly been coming on, Pete. This every year in orthobiologics, there's new developments, and if you're not tuned into it, a lot has changed for the better. And we know how to dose it and treat it more like medicine rather than kind of like a Wild West thing. Oh, we'll just spin some blood and shoot it back in and hope it works. Now they know, like, hey, we know like what platelet counts work better for certain conditions, leukocyte rich versus leukocyte poor, for per given condition. And I'm not an authority in that space, but I just closely pay attention because number one, I want to be able to leverage it as my body breaks down, but also I want to be able to educate people the right way, and definitely stay off Dr. Google if you don't have an amateur if you're an amateur background. There's a lot of information that's coming out in real time, from some great leaders in the space that have really brought this thing out. And, when you look at it, probably a third of most surgeries are actually unnecessary when you factor in the utility of something like orthobiologics, or what they call cell therapy. Not everything requires a knife.
What in many of the people I've talked to in the back, well, in the we'll say the fitness realm or the body realm, many of the guests on the show, therapists, trainers, doctors, etc., a number of them said that the PRP and the stem cells and things like that, phenomenal for most joints, but when it comes to the back, it hasn't shown conclusively as it has in the other joints that it's going to be beneficial. And let's take a disc degeneration as an example. Mm-hmm. And I'll use myself, where I had a very small angular tear many years ago. One of them said, do you think it would be a good idea, or it doesn't appear to be a good idea, that you're going to, if you have a tear already and that now you're going to inject it with the needles or with a needle to try to get it to rebuild itself?
Yeah.
You're just putting another hole in it, and it's just the risk reward ratio just doesn't seem to be there the same way it is for other joints, at least not yet. Do you see from as you said, that's not your expertise, and I'm not asking you to give a medical opinion, but as someone who's connected to that part of the industry, do you share a similar opinion, or have you seen different results with people with backs compared to knees or shoulders or hips?
For discs specifically, there's different camps. Now that's emerging rapidly too, and that's an area I don't pay a ton of attention to. But one of the more recent conferences, so in February every year, there's a conference called the Interventional Orthobiologic Foundation. They have like the leaders in the space come out and do trainings over the course of a few days, and there's always a ton of spine topics. And you'll read some physicians who are doing a lot of intradiscal with a high level of success. Some aren't treating the disc specifically, but like some are going around like the end plates, because there's a migration theory there. Facets all day long. So I talked to the guys who are doing spine, or the gals who are doing spine, and I let them. I just, hey, what's the latest on this, and that's kind of how I get my news as far as it goes. But there are certainly the risk reward of doing some intervention in the disc is definitely a higher. There's a much higher ante, and in all of those need to be considered. If in number one, you need to be seeing like somebody who's an expert in that space.
Yeah, you can't go to some local pop-up in a strip mall that, hey, we can take care of your pain, and you're I mean, you do this thing wrong, and you could really be in some damage that nobody can help you with.
Yeah, absolutely.
In working, you have obviously when you were in the therapeutic side, or before diagnostic, because I think you were a doctor of physical therapy.
Yep.
And so there's I've experienced a number of those things, and all of them, as we talked about before we came on, all of them seem to have a space where they do good. And to me, you know, the golf coaching world, they'll debate pretty fiercely. But when you get into the fitness side and the nutrition side, it makes the golf side look like patty cakes. I mean, these people go at it fiercely. It's unbelievable. But I have seen things work, and I have had many different disciplines on here. I mean, that are somewhat considered extreme. You know, GOTA is not very well taken by the establishment. Those guys, but I have cured my own. What is it? You had mentioned it earlier when your bottom of your foot, plantar fascia. Yes. So I was doing. I have horrendously bad ankle mobility from years of basketball. I'm sure you can appreciate that.
Yes.
You know, you sprain your ankles half a dozen to a dozen times over the course of 15, 20 years, and your ankle mobility is going to be shit.
Yep.
So doing any type of squat without a slant board for me it just wasn't going to happen. So the people I was working with at the time, before we really understood that, so just flare your feet more. But when I'd flare my feet, my knees would pinch in, especially if I had a wider stance. Well, eventually I developed the worst plantar fascia. I had not ever experienced that before and could not get rid of it, and eventually did. But once I did, and I just happened to have some of the GOTA guys on in succession after that, and implementing their outside of the feet parallel with the way I walk. I mean, it was like instantly gone. Yeah. Within less than a week. So, you know, when I hear some people knock certain theories, I'm like, hey, you know, it'll work in certain conditions. The same way different swing techniques will work for different people. That's why we have Jim Furyk's swing. You got Tiger Woods and Rory McIlroy, and all these people do different things, yet they're able to hit the ball the way they want to. Is there one that you have found or a couple that you have, not to put anyone on and on, is there any that you have found more beneficial than others? And, you know, I've said, as you know, I'm working with Brian McGill right now. I mean, Brian Carroll from McGill. Yeah. Yep. McGill camp. And, like I said, I had the GOTA guys on. I've done Eldoa, ART, dry needling. You know, there's a whole bunch of them. Yeah. Have you found certain ones to be better, or is it your experience due to, as again, we circle back to your wide perspective, it's when to apply each one at the right time that will give the best benefit?
Is knowing when to apply each one and never box yourself in. You know, just like nutrition, some of these different camps in the rehab world, it's like religion to them, you know, and they'll every freaking hill's something they want to die on with respect to a principle. And I think you get too, like, you can't be doing that, you know, if you truly want to, number one, be able to teach other people and train other patients to take care of their, I just tell people, like, we're like mechanics for the human body. I need to be able to teach you how to check your own oil, how to top off your brake fluid, you know, maybe replace the brake pads, basic maintenance things. Like, I have to be able to teach you that. And if I'm too caught up in one camp or the other, you know, it just doesn't work, in my experience. And if it is, like, you're probably not as good as you can be if you're not considering these other tools that can work. Okay, dry needling maybe is effective like 5% of the people I'll ever see. Okay, but for that 5% who comes across your way who could really benefit from it, okay, that's a skill you can have to help them get through their issue, you know. And, you know, without getting too specific about any one theory, that's kind of my stance on it. Now, do I have biases towards some? Absolutely. I'm definitely, I relate well to the McGill method, mainly from my days training Olympic style weightlifting and powerlifting. I think it has the most applicability there, and it's easy. It's just an easier kind of round peg solution for that demographic. But at the same time, I'm also wary to be overly principled with that philosophy. So like, for instance, we're working with the rehab director for one of the NHL hockey teams, and training him and his skills in ultrasound. He's an expert we're both experts in the field, but we're having this conversation the other day about a hockey player who is trying to rehab, and he's not buying into their principles because he's a McGill guy. He's seen Stu McGill for certain things, and he has it in his head like he can't move his spine at all. Everything has to be hip flexion. Well, guess what? In hockey, you have to move your spine sometimes, right? You have to skate backwards. You have to, not everything's a hip hinge, And so, I'm sure that this player was, there was probably some miscommunication or the file not found with respect to his time with Stu, and that needs to get revisited. But that's just one example. Like, this guy had it in his head that, hey, we're trying to get you back on the ice, trying to load your spine up again. They've worked through all their initial, like, he's out of pain, all these things now. Now we have to get you back to the demand of being able to play. I don't even know how many games hockey plays every year. Was it like 80 or 90 or something like that?
Yeah, it's a lot. Yeah, it's demanding, man. Those guys beat the hell out of each other.
Yeah, it's not exactly. And you have to prepare your body for trauma. Okay, and so if you want to play professionally, you have to be able to do that. And so that's just one example, and that was very recent. That was like last week. But that highlights, I think that highlights like the question or your thought on that pretty well. That you just have to make sure you're not pigeonholing yourself, and it comes down to the cliche of you have to be a lifelong student. Now, doesn't mean you need to study everything, going 100% into everything you want to, every avenue that comes your way, but you have to have, in my world, you have to have some knowledge of different philosophies and know how and when to apply it. And so, like, when I did my residency, I trained with a lot of Australian and Scandinavian kind of styled physical therapists. One was very Maitland based. One was very Carlton born. And man, I mean, there were a lot of overlapping things, but there were a lot of things like that. Everything from down to the language that they did differently. I was able to take my time training with them and be able to, like, okay, this is good. I like that. I'm going to use it for these situations because it works consistently. And then this is good. I'm going to use this situation for when this pops up. And filing that away, I have a notebook, I write stuff down and I track it, what I learned versus when to apply it. And you kind of have to have an inner tracker of, like, okay, when it didn't work, why was that? What were the factors of why it didn't work? It's not because the technique doesn't work. There had to have been something either you missed or that for whatever reason that there's some variable that day with the patient that just was not going to allow that technique to work. So I know long tangent to your question there, and that could
it leads into more that I wanted to get into with you because as much of a McGill proponent as you are, and you're working with somebody, and for you to say they're pigeonholing themselves, I know exactly what you're saying. Because you are a big fan of McGill method, and then you're working with somebody to say that they're only taking that to an extreme and it's not working to their benefit. I think that's basically the gist of what I'm trying to get across. And it doesn't matter what world-class expert you're working with. And I had this discussion the other day with a friend of mine he's a Czech level 3, and he's got strength conditioning degree, and he's like he's got all the letters after his name. His dad was he's an extremity orthopedic surgeon.
Mm-hmm.
So Justin's very, very smart. He got his massage classification as well, so he could put his hands on it, which he said has made a huge difference in his field. Or his ability to help people. But we were talking about that because he's very, obviously he went to Czech Institute. He knows that system, and he knows McGill, and he knows all these. And I asked him, I said, look, Paul says you need to do this, and Stu says you need to do this. I said, but what I'm finding out is the language that they're speaking they're saying very, very close to the same thing, but I think it's just the language that they speak is the interpretation gets just distorted just a bit, so that the disciplines, as it trickles down through the hierarchy of that system, by the time it gets to the entry level people, they're sitting there fighting. It's like, no, Stu says this and no, Paul says this.
Exactly.
Whatever guru you want to put in. And he goes, if you put all of these guys in the same room, Mel Siff, Paul Check, Stu McGill, they would probably start off where it would sound different, but eventually they would all be agreeing or on the overwhelming majority of the things to do, because the body is what the body is. There's outliers that can do certain things, but for the better part of the majority of the human population, the body is this, and it's only going to be able to do certain things. And these guys with their 40 years of study, extensive, detailed, intricate study, are probably seeing the same thing, and the explanation is similar, even though it might be in a different language at that time.
You said it so well there. That's exactly what I see. I do teach in the entry-level curriculums. I teach radiology and imaging to second-year physical therapy students, and I'm extremely cognizant not to bias them with philosophical camps. I will pepper in, because when I teach imaging to physical therapists, we're not teaching them as to be radiologists. We're teaching them how to understand, just like I mentioned before, when to use which imaging modality and why. Okay, and how to translate a radiology report to the patient in terms they understand. Okay, so that's my main mission there. But what I want to get at is that I can't teach that course without incorporating MSK principles, what they know about anatomy, what they've learned in their classes so far. And school is you have to be, we have to be kind of careful with biasing them too early, even though they're adults. Everybody there is at least 24, 25 years old. And they're forming their clinical brain around what this at this level of education. The getting them to understand, it's just base level principles. Anatomy doesn't change, physiology doesn't change, kinematics doesn't change, kinesiologic principles don't change. If you can bring everything back to that, every camp in the world evolved from that, right? And so you have to be able to, and you're exactly right. If you got all of those experts in the same room at the same time, okay, you can whittle all of their principles down to what I just described, and they would largely agree in principle on probably 90+% of what their whatever the topic may be, and so it in rehab, it always goes back to function, it always goes back to kinematics, it always goes back to anatomy, physiology, and kinesiologic principles. And if you're confused based on what to apply, based on what camp or whatever, I tell people this all the time, just like any evaluation goes to history, mechanism, location, knowing what to do goes back to anatomy, physiology, kinematics. And if there's any kind of confusion, like there's just use that foundation that you have, and so, back to the camps, it's really just that, when you break it all down.
And as someone with your history and clinical experience and working with a number of different people, as well as someone who understands the McGill method, because it is, again, I might be a single-digit handicap when it comes to these things, only because I've talked to, worked with, done a ton of different things and been exposed to it. But and I'm going to ask Stu this. He's supposed to come on in February. It's a long ways away and a lot can happen, but hopefully I can connect. That'd be great. Yeah. But in learning and understanding his system, in particular as it relates to golf, that you want pliability, like a smaller stick, is how he describes it. Yeah. Instead of a power lifter would be more like a tree trunk. Or they do not want any movement in that musculature. They don't want flexibility. They need the stiffness. But my question is as I follow guys like on Instagram, there's a guy I follow called Range of Strength, and I don't know his first name. I think he's very, very good, but he gets into very, very deep stretches. He was a power lifter. He's from Canada. I believe he's in Toronto. Could be wrong. If I am, someone feel happy to post where he is. But he had hurt himself at one time. I think he hurt his pec, and through the course of his rehab, he discovered full range of motion flexibility, like full split squats.
Yeah.
Front and side, full extension of the thoracic spine, where he's doing pull. He's not so much the pullover for lat and chest development, but going backwards for full thoracic extension. And what I see with things like that is it gives somebody the full range of motion, so that when they do the weight training component, that they're strengthening their body in the full capacity that it's meant to move. As you said, you guys are trying to prepare the hockey guy to get back to accepting movement, articulation of the spine.
Yep.
To where he can, you have the theoretical principle of a therapeutical rehab, but then you have the real world application where that spine or joint or everything has to move through the motions of that profession.
Mm-hmm.
So I guess my question is, let's just use golf since we're on a golf podcast. Is it better to get, under the assumption that someone's bone structure, their physical structure will allow a full range of motion? Let's use the squat, for example.
Yep.
The hip joint, the humeral head of the femur and the bone and the hip joint allows for that. Yeah, I know Stu's got a measurement for that. Or Dr. McGill, I'm sorry if I don't mean any disrespect when I say Stu. But let's say that somebody their structure allows for a full range of motion, but through soft tissue and age or injuries that they don't have that. So working on that full range of motion and then adding weight once they have it, would that not give them a better protection through their life and their sport, instead of just saying we're only going to do limited range of motion because we don't want you to hurt yourself or to develop an instability because you have too much range of motion, even though the goal is to build stability on top of that range of motion? That is one question I have for guys in your field and him, hopefully when he comes on.
Well, first of all, I'll say, Pete, that I could tell you're a lifelong learner, and I don't feel like I'm talking to an amateur in the space. Obviously, you studied a lot of this with your own injuries, and you've done a lot of searching, and you're somebody who has sought out, the experts, and you formed some very good kind of insights and opinions around it. I would say, based on what you just described to me, it's certainly the former. There is zero downside. If somebody has the physiologic ability for full range motion, you need to nurture that. It's something that, if you're able to do those things and work strength within the range that they have, it just comes down to that. I want to train them to be strong in all the ranges that they have available, and tailor that to their activity, right? So golf is different than any other sport, okay? And certainly with respect to the spine, and you don't want to train somebody to be overly stiff in the spine in golf, and you certainly don't want to be loading, doing a lot of axial loading for those athletes. Now there's times where I think it's appropriate, and you want to dose it accordingly, right? Maybe just to, if anything, stimulate some kind of piezoelectric effect to callus some bone, but certainly not in a progressive manner. The ability for somebody to perform full depth, and we're talking either light weights, maybe dumbbells, body weights, split squats, lunges, trunk maneuvers, you want to nurture that, because as soon as you go down the road of the philosophy of, I'm only training 90-degree angles, or I'm only training whatever their sport is going to require, well, you're also deprogramming. Bodies are meant to move, planes are meant to fly, right? What happens, when a plane's taken off, it's very rough, right? Until it starts to hit the air, all of a sudden, boom, it hits, smooth, especially if you have a headwind. Okay, that's what the body's meant to do, but with respect to full motion. Okay, and you need to a good coach and a good rehab practitioner will that should be like the base foundation of anybody's programming, in my opinion. So whatever philosophy we want to go down, okay, that's a principle, that's a law that if you violate it, you're guaranteeing them higher risk for injury down the road for something else maybe you didn't intend.
Because one of those principles I used, and he went viral a couple of years ago, and I think most people that would be listening to this in the fitness side and the therapeutic side would recognize knees over toes, Ben Patrick.
Yeah.
One of the things that I implemented as I was trying to come back myself after years of being sick and body damage, was the full range of motion back extension on a 45-degree incline. And I would adjust the incline. I'd go to 30, I'd go to 60.
Yeah.
But and I did it, not, of course, here I was almost 50. So please take this with a grain of salt if you're listening. Don't go into the gym or wherever you're going to go and do a full range of motion and then the next thing you know, your disc herniates and you're saying, well, the asshole got me all hurt. No, I was doing it assisted, where I would hold myself on and then push myself up just to see if it would have the effect of, and I think I'd train long enough and have a very good understanding of the difference between musculature soreness and development versus irritating something that does not want to be moving in that way. So after 30 years of doing these things, I think I have a good grasp of that. I still will probably do something that will set it off, and then you learn more about what's good and bad. But that was one that I found that as I developed into full range of motion unassisted and then adding some weight and then going into single leg, as particular as a golfer, that as you bend over, whether it's to pick up a ball, tee up a ball, picks up your ball marker, or whatever it is, you're constantly leaning forward and you're going to have some flexion in your lumbar spine. It's inevitable. And in life, if you're going to pick up your grandkids or something off the floor, I think that you need that. And then for the first time, once I got to I could do full range of motion, body, 3 sets of 10 or 12. And I'm like, hey, it's actually feeling better. For me, this is something that I think I should be doing.
Yeah.
While keeping somewhat of a neutral spine. I did not let myself go into a full lumbar flexion. I knew that from experience, that was not good for myself.
Yeah.
But what I noticed was as I would bend over to put a leash on the dog, or I would bend over to pick something, a pen off the floor, that the fear slowly was diminishing of when I would stand back up, that there wasn't a grab anymore. I now had the muscular strength to protect the joint that was damaged, and that I'm like, hey, this is actually working for me. So that's why I asked that question, because again, going back to what we talked to earlier, I think that some of the language that these world-renowned experts are saying it in might not translate into the language that the person who's getting into the industry or maybe is established and a fair expert themselves, there's some lost in translation there, because I think there are certain things per individual, as we've discussed today. Yeah,
because even myself, I get caught up in it, and when I listen to somebody else who's a true expert, there's so much information that's already implied, like in their head, and when they're talking about these principles, like they're not covering all that. They're skipping to like the super advanced method that one shouldn't just skip over to get there, right? And so absolutely, I think that when we talk about it's really about bulletproofing your body for life. I mean, this is a longevity game. If you want to be kicking ass when you're 80 or 90, like you can't be average in your 40s and 50s. You have, and what that means is you have to be utilizing your body for what it was meant for. Body was meant for, it's meant for full ranges, right? And we slowly, things over time kind of get stripped from us, with respect to movement based on whatever activity levels were, false training methods, or doing things that weren't right, and it is hard to go back and repair it. Oftentimes it can't be done 100%, but a lot of the time we can get a lot of it back, more than maybe what we think. And the brain remembers kind of trauma too. Okay. And so we go back to, when something new happens, we revert back to what our mental state was 15 years ago when we had a similar injury, and we all of a sudden pre-program ourselves like, oh, it's going to be like that again, when it may not be, and it doesn't have to be all the time. And so there's a huge mental component to all of this that I think that must be kept, that really we should guard. Okay. And as being a lifelong learner, going into any injury or coming out of any injury should also be met with kind of new thought experiences as well around, how do I want to apply based on what I've learned? Who do I want to seek out that can give me something new that could help me through this stretch? And that's the game we're all playing. It's a long game, and being a lifelong athlete, it doesn't matter what age you are. Okay. We all have things we want to do and be able to use our body for. And that requires, again, goes back to basic kinematics,
I think, yeah, what you just touched on, I think Dr. Peter Attia talks a lot about the Centurion, the triathlon or decathlon that he wants to compete in.
Yep.
He's very big into that. And I think one of the things I heard him say was at 50, and now this resonates with me because I'll be 52 this year, but at 50, you need to have the HRV or the cardiovascular capacity of somebody 30. Or that is a goal to set to get to, because you're on the downslope of the life cycle, and it's going to, your last 10 years it's going to drop fast. So you need to have a surplus in there, like an IRA account or a retirement account. You need to have a surplus, because at some point you're not going to be able to build anymore. You're just going to be maintaining, and then eventually you're going to have to cash in those coupons that you deposited. I know Andy Galpin has talked about this quite a bit. I listen to a lot of his things, and I think he's great. I actually asked him to come on. I don't think I was big enough yet at the time. I know he's probably very in high demand. I think he's great. I don't know if you've ever come across him or not.
Yes.
He's another one who's just very, very full of information, and you just listen to guys like that, like, God dang, there's so much out there. I don't know how they keep up.
Yeah, no, me neither. And certainly that I pick and I listen to a lot of those people, and not super in depth, but I kind of pick what I want to apply and what I want to teach other people based on what's emerging now. And it comes down to vitality comes down to how you're able to move your body, move your joints, your muscle mass, your lung capacity, your ability to blow off CO2 relative to your O2 intake, and that's your VO2 essentially at the delta. I met my wife in undergrad. We worked in the human performance lab at Humboldt State University, and so we'd run these tests all the time on our athletes and people in the community, and that's evolved so much since I was in school. But I still remember my time there very fondly. Those principles haven't changed with respect to how we're measuring one's ability to utilize oxygen and blow off carbon dioxide, because that's a reserve. Everyone should, if you want to play that long game, especially if you want to be active as long as possible, you have to be mindful of it. Okay. And I think that in combination with, I think have you ever heard of there's a physician, her name is Gabrielle Lyon. Are you familiar with her?
I've heard who she is. Yeah. I'm not very familiar with her, but I remember reading about her somewhere.
Yeah. She's, and I'll just keep it condensed. Her brand of medicine is muscle-centric medicine. So she's a geriatrician. She did her studies in working with people in geriatrics and why people develop dementia, cognitive decline, dealing with those people. There's got to be like what's the denominator here? And she started to piece together the relationship between muscle, glucose uptake, insulin sensitivity, and the brain. And how many, and I'll just break it down and say, generally, if you keep muscle mass, if you keep as much muscle mass as you can, as you physiologic have in the tank, as long as you can, that's the best way to ward off cognitive decline. And I think those interrelated, the hormones, but the pituitary, the IGF, insulin sensitivity, glucose utilization, okay, that's muscle. Okay, and people who develop those diseases have unhealthy muscle systems, and the relationship between obesity and muscle is like, it's not like, it's not that people are obese. She says they're under muscled,
Mm-hmm.
and it really, some of those things were already kind of intuitive to me, but to hear somebody else say it in a way that maybe I thought I could never put into words, and I'm still kind of forming some thoughts around it. And so that's why I'm kind of like not smooth with the delivery here. It's such a and it makes so much sense, Pete. And so when you start to, go down this road, and we're working with other people, and I know you are, and especially how to apply it, the all of this has, all of this has a way of meshing together, and it doesn't have to be complicated. Okay. You have to eat, you have to do some resistance training. You have to move your body, use your joints to their full capacity, for whatever you have available. It's going to be different for everybody. Okay. And you got to eat protein, because that's what's going to feed the muscles.
The common denominator is that all these top people are saying is, it's not hard, people. Humanity has done this for thousands and thousands of years.
It's free.
Yes, it's free.
Yeah.
But I got to ask you about your book. But before I do, let's get your input on one other thing, because I've done it for a number of years, even though it's been on and off. And I have done it consistently lately for about the last 5 months. But cold therapy, ice baths. Have you played around with that at all? Have you experimented with that?
I have.
I asked because I've had from your area, Dr. Seeger, who's the CEO, owner of Morosco Forge, is right in your backyard. They're based out of, they're in, I'll say Phoenix, because the city, but I don't know their exact town. But he's great. I love him, and he's becoming one of the foremost ice therapy researchers out there, which is great. I love talking to him.
Heat therapy, cold therapy, love it. It's free. I mean, saunas cost money. If you want a nice cold bath, it costs money, but you can just do an ice bucket bath either in the bathtub or get a barrel. I'm not going to pretend to go over the science of it all. But
I'll tell people, go listen to my episode with Dr. Tom. They can get all the science they want to.
Honestly, it comes down to doing hard shit. You're developing a will and a resistance to the inner person who doesn't want to do something that's hard. Okay. And that's jumping in an ice bath. Okay. So you're getting dopamine. Brutal. You're getting dopamine the hard way. Right. And it has so many other physiologic effects. Okay. But for me, it's more mental. So I have a sauna at home. That's my thing. I'm all in on the heat therapy. And really pushing myself, this concept of hormesis, the leveraging healthy stress, right, to, pushing the barrier of it. I enjoy the sauna. However, I don't enjoy the last 10 minutes of the sauna, and I don't look forward to it. And so I'm developing a stress level around what it takes to fight through that. Okay. And there's ton of research on these therapies that have massive impacts on your body's hormonal panels. My own blood work changed massively. I'm in my early 40s, and when I'm in all this shit that's free, watching your health, watching, good sleep habits, doing some resistance training, not eating a crap diet, ice, heat therapies, all of those things. I saw it play out. My testosterone went from like 300, 400 to 800, 900 in a matter of like less than 6 months.
And most of that was your diet, your training, and the sauna. That's amazing. That's awesome.
Yep. Training was the one constant, but I did cut out I did in my diet. I cut out essentially all breads and carbs, like just cut it all out. I did start taking broccoli sprout extracts, which also cut my PSA in half. And I don't think it was a one-time thing because I did it. I had the blood work done every 3 months, and in each of those 3 months, there could have been some other factors too. I don't know, but
that's
anyways,
awesome that it's
but the one thing I did that I really put a lot of effort into was the heat and cold therapy. More heat than cold. I would love to get like one of those higher end ice baths at the house, and I'm figuring out how I can get that done. But I'm all in on that stuff, man. I love it.
There, the sauna. I was doing that as I got back in training about a year and a half ago. I started doing the sauna because Dr. Rhonda Patrick. I've listened to a lot of her talks. She's exceptional. I highly recommend everyone go follow her. But when I turned 50, I went for my cardiology test because you got to do that thing as you get older. You catch something. If you have something, you got to catch her. That's the best defense you have outside of the lifestyle that you just described. But the girl who's doing the stress test, she looks at me and says, "Do you run marathons?" I said, "No." I said, "Why? Is something wrong?" She said, "Your heartbeat is like, for your age, is off the charts good." She says, "What do you do?" I said, "I just sit in the sauna for 10 to 15 minutes after every workout."
Yeah.
Because I was doing cardio, but I hadn't got into, it was like zone 2. It was nothing stress. It was, I kind of done some sprint, hit 30 seconds on, minute off for, 10 minutes and a little bit of that, but nothing extensive for her to say, this is off the charts good as far as your heart's concerned. And I was like, really? But one question I have for you, because you've probably done it more than I, is, and as I'm getting back to the gym after being out of it for 4 months, when I'm going back in, the thing that I struggled with before, and I think the simple answer will be obvious, but I want to get your opinion as someone who's better at it than I am. How do you stop from getting a sore throat from the heat that you're inhaling, even if you have your mouth closed? Is it just you got to crank the heat down and slowly build back up like a muscle, or is it something else that I'm?
Are you talking about in the sauna?
In a sauna, yeah.
I've never had that problem, but and this is totally anecdotal, so I don't have any like research to back it up, but there's some tools you can buy. Like one's called, like, it's made by a dentist in Hawaii. It's called nose breathe. And so like you insert this thing in your mouth, it forces you just to breathe through your nose. It elevates the tongue. Mm-hmm. I think what people's tendency is they want to get everything through their trachea, through the oral cavity. And if you shut that off, it goes away. So like I used to have, it was like a form of, heartburn. And it was all because I was just breathing. I was just mouth breathing too much. So I would just see if you can shut off your mouth breathing and do it with that tool. Because if you just try to tape your mouth or just force it closed, your jaw needs to be a little bit more widened. It needs to be slightly open, and that tongue needs to get lifted in order for you to facilitate the full effect of the nose breathe. So I would try that first and see if that does anything.
Okay. Yeah, I had Alex Romagnoli on. He's an instructor for Buteyko breathing, and he works with Andrew McEwen quite a bit. That was a very fun show and interesting to do. He was in Italy when we did it, so not only a time difference, but he was great. He said he can get Andrew to come on, which I mean, that'd be a pretty tall order if I could get Dr. McGill and then Andrew McEwen on, who is the king of the nasal breathing. That would be very, very cool. Especially, and I know some people might say, what the hell does this have to do with golf? Okay, well, first of all, your recovery from playing. Go in a sauna, it's going to do wonders for your the fluids. As you talked about synovial fluid and everything else earlier as we got started, that what you test, someone comes in to see you, okay, you got a jam up of these fluids in your joints. Go do a sauna. That's all I got to do. Well, let's start there. 10 minutes after you practice or you go work out or whatever you're going to do, go in a sauna after you're on the golf. It will help in the healing process of your body. The cold therapy is obvious. Getting that after, it will reduce inflammation. Getting it before your workout, it could increase your testosterone.
Yep.
So a number of these different things that the breathing, all sports psychologists, the first thing they tell every athlete, go back to your deep breathing because you're going to start shortening your breath cycle as soon as you get under pressure. All these things help, and
Yep.
they help in life and they help in golf.
Yep. Golf people are junkies, man. And they want to play as long as they possibly can. If you want to play as long as you possibly can, you need to maximize whatever you can outside the course to allow your body to make that happen. Okay, so that's where all of this ties in, Pete. And I appreciate you bringing up this wide range of things, because I'm passionate about it too. Even though I don't play golf, but I respect the field, because every golfer I've ever worked with is just I have things in my life I love to do so much, and I relate to that love, based on my own set of values. And so being able to do that as long as you want to do it requires some extra work. It requires some extra diligence. It requires a little bit of extra effort to make that, a reality. And that's the purpose of getting this information out there.
Now, you've got a book that the rumor is you're working on putting together.
Yeah.
Is it going to be broad, like what we've talked about today, or is it going to be more specialized for the ultrasound specialty that you have, or is it going to be both? Tell us a little bit about it.
It's going to be pretty specialized, because our market is universities, and we want to get it into curriculums. So it's PT and imaging, so physical therapists and diagnostic imaging. It'll incorporate all the imaging modalities we talked about earlier: ultrasound, CT, MRI, and X-rays mainly, and how it relates to the physical therapists. Because currently there are some great books out there that that are very much in the weeds, and they're very good. But I wanted to have something more like a pocketbook manual of like somebody can have in the field and know like what form of imaging to use and why for a given situation. And really have it be more philosophical based rather than technical and detail based. So that's kind of the mission. We are working with a publisher, and so it's the first time for me to work with a publisher, and there's some challenges with that, but it's a topic I'm really passionate about. I'm looking forward to it taking shape.
But keep me posted on that.
I do have a co-author with that as well.
As the body and the fitness and everything, and of our theory, my theory, and the podcast and the coaching is, we've had a number of therapists and trainers on. If we can, when you get closer, let us know, and we'll help push that out the best we can to our small audience.
Absolutely. Yeah. It's scheduled to come out not till fall of next year. So fall of 25.
Cool. You got a few minutes left. We can do emergency 9 and then wrap up and get you on.
Sure.
Enjoy your afternoon.
Yeah.
All right. So 9 questions just at random, the first and last for everybody on the show in almost 105 years. We passed the 5-year mark a couple weeks ago. So Everybody's had the first and last one the same, but the ones in between, we try to update every so often.
Yeah.
So first one is, I know you're not a golfer, but I'm sure you watch a Ryder Cup and the big events. And if you were playing golf and you had a walk-up song that you were going to walk to the first tee to, kind of like they do in the WWE or the UFC that had it last night, what would be your walk-up song you want them to get the crowd going and cranking?
Oh man,
high decibel level.
Now the band and the name of the song is escaping me, but do you remember that movie Friday Night Lights?
Mm-hmm.
Okay, do you remember that towards the end of the movie when they're walking out to the state championship and they're walking out of the tunnel? That song.
I don't remember it vividly, but I remember that part of the movie.
It is escaping me now. But if you just type in on YouTube or Google Friday Night Lights walk through tunnel song, that's the song.
All right. Let's see. If Hollywood calls and they say, Colin, we've been watching your career. We're very impressed. We want to make a movie about your life, and we're going to let you cast whoever you want to play the character of you. Who are you going to tell them to put to play you?
Clive Owen.
That didn't take long.
I love his acting style. He's made some really awesome movies. He has that's my guy.
You know, it's crazy. One of his earlier parts that before he got bigger and was lead, he was in one of the first Bourne movies where he was the assassin
Yes.
trying to kill him in the field out in the
Yeah.
country. I remember it's like, holy shit, that's Clive Owen.
Yeah.
All
Yeah.
right. What is an inexpensive purchase that you love? It's not very expensive, but you just love to get it. Or you love using it.
Cold laser.
All right.
There's little handheld cold lasers you can get now on the market for aches and pains that come up, and there's a ton of research that's very good with it. Now's a good a time as ever to invest in one, and they're not that expensive now.
You get those on Amazon?
You can.
Okay, cool. I'll have to check that out because I got a lot of aches.
Yeah.
I'd be sitting there at night and all of a sudden something, I'm like, what the hell did I do here? It's like, why is that just all? And okay, I'll got to get into that. The most used app on your phone?
Most LinkedIn.
You know, I got to get a podcast page for there. I never thought that you should, and then I've been reading up on getting growing your channel and your show and everything. Says you have to have a LinkedIn. I'm like, okay, I guess if that's what I got to do, then that's what I'll do.
Yeah, you should.
If you could put a restaurant chain, anyone you wanted to, in your kitchen, who would it be?
Chipotle.
Okay. Spoken like a true Southwesterner.
It just, you can never go wrong with it, man. You know, it's there's always something in my diet I can get there, and I double steak every time.
Cool. If you could sit in a golf cart for a few hours and talk to anybody you wanted to, who would it be?
Charles Barkley.
That'd be an interesting one. I watched this morning, Sundays I wake up and I just kind of lay in bed for a half hour and got an iPad there. Which I know Huberman says you shouldn't do that shit, but I mean, come on, it's one day a week.
Yeah.
And I'll just watch YouTube videos. And I watched today, there was a guy, this is the kind of stuff I'll do, just kind of get a laugh in the morning. There's a guy I guess he's one of the top Barkley impressionists. And he interviewed Charles Barkley, and Barkley's just sitting there laughing his ass off. He couldn't stop laughing. That was great. So ironically, you choose him. This is an odd one. I don't know how the hell we came up with this one, but do you shower in the morning or in the evening?
Evening.
Okay. Like I said, how we came up with that, I don't know. What's the significance? I have no idea. Outside, it's just a goofy question that we throw in at the end. Would you rather play Augusta National or get 4 badges to the tournament for life?
Oh, probably Augusta National.
You like to play it, or you get the badges to the tournament?
I would even though I don't play, I would. That would be it. That experience, you can never recreate it. And
yeah, that's pretty special.
And being I'm not like a total golf guy. There's just an aura around Augusta that whenever I've never been there, it's probably a bucket list thing. I've just, that part of Georgia, man, it seems like it's.
If you haven't, get on the lottery. You can register on masters.com.
Okay.
Make sure you get on there for the practice round and or the regular round. You like my brother had been in it for 15 years. I think he won this year. The first year I go because I'm still a PGA member. I can access it, no charge.
That's awesome.
Part of but I signed up just for the tickets. When the first year I signed up, I got 4 for I think Tuesday's practice round. So it just makes it easier. So yeah, definitely sign up for that because you might get them, you might not, but at least you're on there and you have the opportunity.
Yeah.
I bet not to rub it in. I mean, Augusta's 2.5 hours away, so I've been there a dozen times at least.
Yeah.
So I don't go much anymore, which sounds very cocky. But it's just like, hey, I've been in, but I've never been to Phoenix or the desert. So you got me on that. I've never been to anything out there. And then the last one, this one everybody gets. I'm always curious to hear the answer, and usually goes generational. In your opinion, as far as golfers are concerned, who's the GOAT? Who's the greatest of all time?
Oh, I mean, Tiger Woods.
Yeah, he's in the lead. Definitely in the lead.
I imagine he is, 5%. And I think Pete that I'm about the same age as he is, and so that was when I actually first started paying attention to golf. My dad watched golf, and it was, you know, Jack Nicklaus, Gary Player was his favorites, and a lot of respect, obviously, to that generation. So, and I'm not nuanced enough to have the generational type player conversations like I would with like basketball or somebody, but yeah, when it comes to that question, I would say Tiger Woods.
Yeah, you're not going to get much of an argument back on that one. That's
Yeah.
why it's been fairly close, and again, generational.
Yeah.
I haven't had as many people, let's say 65 plus, as I have 65 under. So Tiger is in the lead on that, but it's always, I'm just curious to see people's answers. I have had a few outside of those two, but it's just one we got to put in there because it's like the LeBron Jordan thing, depending on who you watch when you grew up.
Yes.
And all those other things. And we won't even go there because we can make a whole podcast on that.
Yes.
Now, is there anything we missed? Did I leave out anything? I mean, we touched on a lot.
No. I mean, we did touch on a lot, and then nothing we missed that I feel the need to go back and cover. I just, you know, really appreciate having me on, Pete, and allowing me to share just some of my background, my passion. We share a lot of those same passions, and you know, it's very evident whenever we talk. So, you know, again, just my appreciation to you for having me on, and thank you.
Happy to. And we'll have the links to where you are. So if you're having some physical issues in your joints or anywhere else and you have not found relief from anybody, please check out Colin. I'll have a link to your website. I looked at that. That was very, very educational. So people can watch videos on there and see what you guys do. And hopefully they reach out to you. We'll have your email and everything else on there. And they can reach out to you and get some relief and get back to living an active lifestyle and playing golf and doing a lot of other things.
Absolutely. Thank you.
Awesome.